Welcome to Chapter 44, Part 1, the Genitourinary Tract Disorders in Pediatric Patients. Let's briefly do an A&P review. All renal structures, including nephrons, are present at birth. Over the first 5 years of a child's life, those nephrons grow in size, not number, as well as mature. Bladder capacity is about 20 to 50 mLs at birth and increases as the child grows. A 6-year-old has about an 8-ounce bladder. Add 2 to the child's age, and that's their capacity. Children less than 2 are usually not potty trained because of insufficient nerve development to control the muscles needed for bladder control. The reproductive systems are functionally immature until puberty. So, common diagnostic tests. Look at Table 44-1, page 1396 to 1399. Radiologic and other tests of urinary system functions. Make sure to note comments and nursing responsibilities. So we have the urine culture sensitivity, the renal bladder ultrasound, the testicular ultrasound, a KUB, a VCUG, a cystoscopy, and a urodynamics. Briefly, urinary tract infections can occur in the lower or upper tract. Lower UTIs are such as cystitis, like bladder and urethra. And upper UTIs are pyelonephritis, such as the ureters and the kidney. Bacterial. Common culprits are E. coli, about 80% of cases, staph, Klebsiella, Proteus, Pseudomonas, Enterobacter, and Enterococcus. Asymptomatic bacterial, simply put, have bacteria in the urine, but there are no symptoms. Recurrent, repeated episodes are symptomatic UTIs. Persistent, infection that persists despite antibiotics. Febrile, presence of fever usually indicates pyelonephritis. Cystitis, inflammation of the bladder. Urethritis, inflammation of the urethra. Pyelonephritis, inflammation of the upper urinary tract and kidneys. Urosepsis. Febrile, UTI with systemic signs of bacterial illness, positive in the blood cultures. Urinary stasis greatly increases the incidence of UTIs. The urine is supposed to be sterile. The body tries to keep it sterile by diluting it out to decrease possible bacterial load. Bacteria usually prefer an alkaline environment, and urine is naturally acidic. There is some evidence that suggests that daily concentrated cranberry juice will increase the acidity and therefore decrease incidence of UTIs. Two common causes of urinary stasis. There's the neurogenic bladder. That's the incomplete voiding due to damaged nerves, and these kids pee all the time as babies. They pee constantly. Then we have VESICOURETERAL reflux. This is backflow of urine up the ureter during voiding. Other causes of UTIs: constipation, poor hygiene, uncircumcised males, sexual abuse, activity, masturbation. So why is constipation such an issue? Because it can prevent the bladder from emptying and it's harboring bacteria. Little girls also have a shorter urethra too, so it's a shorter pathway for infection. High incidence of infection among uncircumcised boys is greater than in the boys that are younger than 3 months of age. You may also refer to your MedSurg book for UTIs for the pathophysiology. The pathophysiology is consistent in pediatric patients as it is in an adult. So let's talk about symptoms, diagnosis, and treatment. So why do we care about UTIs in children? Besides the fact that it makes them pee a lot and it hurts, it can lead to renal scarring and hydronephrosis. I know you all remember that renal scarring is associated with poor renal function, which affects hypertension, proteinuria, and end-stage renal disease. So it is a big deal. In fact, the risk of renal scarring increases with UTIs in children less than 1 year of age. Delay of diagnosis and treatment could lead to structural defects and nerve innervation issues and recurrent UTIs. Symptoms in babies, usually fever, hypothermia, failure to thrive, poor feeding, vomiting, diarrhea. Toddlers often have the classic symptoms: stinky, cloudy pee, painful urination. Some UTIs are silent and discovered on a routine well child checkup. Diagnosis, of course, is a UA, a culture and sensitivity if needed. Urine is collected in a variety of ways: a cath specimen, a midstream clean catch, and a suprapubic bladder tap. Treatment includes eliminate current infection. You can use such as penicillins, sulfonamides, cephalosporins, and nitrofurantoin. Identify contributing factors to reduce the risk of reoccurrence. Prevent systemic spread of infection. Ensure adequate or increased fluid intake. Preserve renal function, and if hospitalized, give medications, IV fluids, and monitor intake and output. So let's talk about VESICOURETERAL reflux. As the name suggests, there is a reverse flow of urine up from the bladder to the ureters. This happens when the ureter opening at the point where the ureter joins the bladder does not close off like it's supposed to when the bladder is full. This causes a UTI. That bacteria can infect the kidney and cause renal scarring, hypertension, and chronic renal failure. When you look at this picture, you can see how when the bladder fills, the ureters are supposed to be pinched off. With reflux, they do not. Usually presents as a frequent UTI diagnosed by renal ultrasound and VCUG, can lead to renal scarring, hypertension, or chronic renal failure. The goal of treatment is to prevent the UTIs and renal scarring. Treatment: prophylactic antibiotics, surgery, and deflux procedure. Nursing care: medical teaching or medication teaching. Void every 2 hours, double void, avoid constipation, and monitor for signs and symptoms of infection. Okay, we have obstructive uropathy, structural or functional abnormalities that obstruct normal flow. Backup of the urine above the obstruction causes hydronephrosis. Condition may be acquired: unilateral, bilateral, complete, or incomplete. Early diagnosis and surgical correction are essential. This picture just shows common sites for urinary tract obstruction. Look at figure 44-2 in your book. Let's briefly discuss the defects of the GU tract. We have the inguinal hernia. You know what this is already. It's usually fixed surgically. We have a hydrocele. That's fluid in the scrotum, and it's fixed surgically. We have phimosis. That's narrowing or stenosis of the prepucial opening of the foreskin. We have hypospadias. This is the urethral opening on a ventral side of the penis. Epispadias, urethral opening on the dorsal side of penis. Chordae, ventral curvature of penis, often associated with hypospadias, fixed with surgical release of banding that causes the curvature. Cryptorchidism is a fancy name for undescended testes. They may need surgery, it may resolve in time, or may treat with HCG in an older child. Or we have exstrophy of the bladder, basically when the bladder protrudes through the abdominal wall, must be fixed surgically. See table 44-4 on page 1403 of your textbook. And ambiguous genitalia. Okay, let's briefly talk about hypospadias or epispadias. Epispadias and bladder exstrophy occur together. Bladder exstrophy is very rare and is when the bladder extrudes through the lower abdominal wall. Females can also have epispadias with a urethral cleft that extends into the bladder. Corrective surgery is usually done around 1 year of age or by preschool years. No circumcision. Tissue is needed for surgical correction. Stent may be placed to maintain urethral patency. Monitor urine output and stent patency and prevent child from removing the stent. Surgery is usually done between 6 to 12 months of age. Provide usual post-op care. Discharge teaching. No tub bathing until the stent is removed. No riding toys. Don't carry them around on a hip. Limit activity for 2 weeks post-op. Encourage fluids. Complete the round of antibiotics. Watch for signs and symptoms of infection such as fever, redness, swelling, pain, odorous urine, and change in the urinary stream. It's normal for the urine to be blood tinged for a few days. Call the doctor if urine is leaking anywhere other than where it should be. This concludes part 1 of chapter 44.